it's like your role as a provider and your role as a clinician that really counts. And I think we can't lose sight of that. You always have to remind yourselves too. Like I try to tell our medical students and our residents about that when they're stressed about those things, that you've done so much already. You're like the 0.0001, but you're like phenomenal. And so please don't think you're like any less because you're not doing research or you didn't get that grant or whatever. And I think you need to have that modeling, and it starts from the top up.
Welcome to the 9th episode of Shrinking Burnout, the podcast with two psychiatrists who want to talk about clinician burnout. I'm Andy, and I'm joined here with my co-host, Varsha.
Hi, everyone.
And today we have a pretty special guest, Bernard Chang, who is a physician researcher in emergency medicine. I think it's going to be pretty interesting to have him on the podcast because we had a podcast a couple episodes ago where I talked a little bit about the burnout controversy in research. And I think I was pretty hateful in criticizing some of the existing burnout research. And what better way to debunk some of those things that we talked about than to actually bring a burnout researcher on the pod. So Bernard, why don't you tell the viewers a little bit more about yourself?
Sure, great. No, it's a real pleasure to meet you, Andy and Varsha, virtually. And hi to all the listeners. Really nice to kind of be on the program. So I am an emergency physician at Columbia University, but actually before I went to med school, I was actually a research psychologist. And so I've had this long, I was looking at work both with schizophrenia and death by suicide in the acute care setting. And I've kind of carried that forward in my work as an emergency physician. So I've been really fascinated kind of the intersection of acute mental health and behavioral health emergencies. And in particular, I've really looked at the environment and the impact of the environment on, say, patient outcomes. So, for example, we've been looking at stroke survivors and folks with acute coronary syndrome, like cardiac events, and the development of post-traumatic stress and even PTSD in some of these survivors. And we've looked at the impact of the acute care of the hospital situation, like crowding, being in a very kind of loud environment and kind of being in this sustained stress, dysregulated sleep environment, and how that impacts your psychological recovery after medical illness. And looking at patients, I actually started thinking to myself, well, what about not just the patients, but what about the clinicians who are not just exposed to this in one hospitalization, but are actually exposed to this for years on end? And so that really kind of piqued my curiosity in looking at clinician well-being and burnout, for lack of a better word. And so I've really tried to kind of straddle this line between my interest as a health psychologist, looking at the impact of psychological outcomes on cardiovascular outcomes, as well as just as an emergency physician, what are the things that, as a frontline provider, we are exposed to, and how do we kind of, in addition to describing the issues, how do we actually address them?
You mentioned burnout, for lack of a better word. I guess I wanted to ask your opinion on currently how burnout is constructed, how it's defined, and what your opinions are in terms of trying to get past this nebulous term that we have right now.
Yeah, no, it's a really great question because I think that the construct of burnout has been used very interchangeably, and it means a lot of different things to a lot of different scientists or clinicians or individuals. My working definition of clinician burnout is really kind of talking about the emotional exhaustion or the psychological stress associated from your occupational position. So it's really kind of for lack of a better word, an occupational hazard of health. And I think one of the big challenges with burnout historically has been even the term burnout itself is kind of, there's almost what a level of individual attribution to this person that somehow they quote burned out or flamed out. And there is this implicit dispositional kind of like attribution to burnout. And what I've really tried to do with most of my research is really identify that, yes, there are perhaps some state or trait factors involved with that, but really we also have to understand that there's tremendous environmental or occupational factors that are really playing involved. And these external stressors are really potentially playing a significant role in the development of stress in individuals. So when I think about burnout, I really think of it as more of like the end outcome of this combination of internal, external, and dynamic changes that are resulting in this adverse psychological reaction in individuals.
In terms of this adverse psychological reaction in individuals, getting into your research and how you began to address that, what specifically have you looked at, and how have you tried to address this psychological reaction that you see?
So one of the things that what I've tried to do, just thinking about it as a clinician, is really um, ultimately trying to think about it from a practical standpoint, insofar as it's interesting to study a phenomena, but as a frontline clinician, you want to actually hopefully identify modifiable interventions, things that actually can improve, that we can change. I mean, there would be certain things, like going back what I was saying before, that perhaps some state factors or trait factors that are a little bit difficult from an intervention standpoint to kind of like change. But there could be some things in the occupational environment that could really impact or improve providers' well-being. And so what we've looked at is studying emergency department crowding and volumes and the acute care environmental factors that could potentially play a role in psychological well-being. And so some of the work that we've looked at, specifically before talking about clinicians looking at patients, we found that folks who are evaluated for an acute cardiac event, who are treated in a very crowded emergency department, when you quantify that by tertiles, you find that basically there's almost a linear relationship where that essentially, if you're in an emergency department that's more than double the volume of another emergency department, more quiet time, your actual self-perceived acute stress symptoms you report almost double compared to an individual who's not in that situation. And I think what's all the more remarkable is that about 1 in 6 individuals who have a cardiac event go on to have PTSD 30 days out after their cardiac event. And if you look at some of the vulnerabilities for those folks who go on to develop PTSD, we actually accounted for about 20% of that variance with some of the crowding. And so what's remarkable about that finding is that there is something about the environment itself that could be influencing not just short-term, but even like kind of longer-term psychological outcomes. And so we took that model, looking at it within the world of burnout, and we've started looking at it among providers, specifically emergency nurses and physicians. And we have some pilot data. We just are about to start a large prospective cohort study of about 350 nurses and docs. We're going to follow them for 5 years and look at the development of both psychological well-being and cardiovascular health as well. But in our initial preliminary data, we tracked 12 clinicians. And what we found actually was that their scores on the Maslow Burnout Inventory was actually associated with actually their exposure to working in the emergency department for prolonged periods of time over 6 months with high crowdedness. And so what I mean by that is that the clinicians who worked in the EDs that had, on average, higher levels of crowding and higher levels of patient acuity were the ones that were associated with higher levels of emotional exhaustion on that subscale of burnout. So that's one example, Andy, of at least something about the environment that could potentially be influencing psychological well-being in clinicians.
And that's definitely really interesting, because I know we could certainly think about crowding and also the environmental effects of care for psychiatric patients as well. And I've definitely come across this within the emergency department. I think the milieu or the actual environment itself is not necessarily always the most therapeutic. And I think it's like great research that you're focusing on also the effect of crowding on burnout, or level of acuity on burnout as well. I'd be curious to hear if there's any particular interventions that you found have been helpful in at least mitigating some of this distress or decreasing the level of burnout that physicians experience.
Yeah, so what we've been trying to do is we're still, and again, like this is just more of the preliminary data. So I think our prospective study will probably with more power and more clarity really address some of these questions. But some of our initial hypotheses were, in addition to crowding, just the idea of the sleep dysregulation that we have with shift work. You see there's a really robust literature in shift line workers talking about the impact of sleep, of short sleep and sleep dysregulation, both on metabolic outcomes like your obesity, physical inactivity, cardiovascular risk, in addition to psychological stress. And so the question is for us as clinicians is there like an ideal shift schedule, like to stack your shifts, to not stack your shifts, or how do you find that? What we found is that with some of our preliminary work that shorter shifts, like shorter but more frequent shifts, like 8 hours seems to be kind of like the sweet spot, at least working in the emergency department, for kind of like that sweet spot of you're not seeing as much high levels of stress levels, but at the same point, you're still kind of like actually, working and feeling kind of like cognitively engaged. I think that the other things that we've been trying to play around with on patients and to be a little bit more tricky on providers is also this idea of with ED crowding, we have other factors such as noise and like if we introduce like white noise or even like VR devices like the Oculus, we've seen some encouraging preliminary data with very small samples that you literally can get, you're in this chaotic emergency department, you put on your Oculus and now you're looking at like, you're in a meadow somewhere and, can that sometimes help a little bit? But I think that goes to your point, Barsha, about some of like the modifiable things, but I think it doesn't really address, though, to Andy's point, some of what I call the more system level factors that are still influencing burnout, or what I call a lot of people have been now adopting the term moral injury for providers. And I think that really is now extending into what I call, there's certain things that we can try to change in our hospital milieu, but there's also things that we really need to focus in on at the system and actually at the policy level. And I think the first thing is that one of the things that I've begun really developing a strong interest in is really this destigmatization of physician mental health, because I think that there really is this kind of superhero complex that our profession really has, which is on one level, it's very flattering and it feels very cool. Like here in New York City, for example, we have like a 7 p.m. clap where people are just clapping and applauding like essential workers, and it's really kind of humbling.
Is that still going on?
Yeah, it's still going on. Yeah,
Oh,
it's still
cool.
going on. Yeah, it's really kind of inspiring. But on the flip side, I would say the counterpoint to that, though, is that there is this culture of, well, you're supposed to be really tough and really resilient, quote unquote, and that really doesn't lend itself to folks who are feeling more fragile or are feeling more vulnerable to kind of seek help. And then I think there's also things at the policy level too, is that, I was just doing my reaccreditation in last month for my hospital credentials, and there still is like this checkbox about have you ever been treated for a mental health condition? And I think that I can't help but wonder how many clinicians sometimes think about, should I click yes or no in this, because it might have some impact on my my ability to practice my profession. So I think that there are things that can really help with reducing kind of the psychological stress that we're experiencing as clinicians. But I think it's going to be really this multidisciplinary approach, both at the department level, to the hospital level, but then also, really kind of at a societal and even at the policy level.
Absolutely. And I think, as you mentioned, the fear that a lot of people have when it comes to divulging, seeking any mental health services, especially on paperwork for a new job, I think it can be extremely daunting, just concerning about whether or not there's going to be any potential retaliation or consequence on your career. And I know personally in medical school, there was a lot of people that I remember would have this conversation together wondering what we should or should not disclose. And I know there's a lot of misinformation out there as to where exactly that information goes, who's reading it. Is there actually going to be any impact on your actual career, whether or not they're going to hire you, for example? So I think also dispelling some of that misinformation will be really important. And I think that'll have to start from the level of medical training, medical education during med school, really. That's where it starts.
Yeah, no, I completely agree. But maybe I have a question for Andy.
Yeah.
I apologize. I didn't get a chance to listen to the earlier podcast about the skepticism about burnout research, and I would love to actually hear. I enjoy like hearing the counterpoints or the skepticism about this too, because it actually informs both the way that I think folks who study burnout kind of continue to look at the questions, as well as it's always good, I think, to get kind of a critical ear or kind of like the counterpoint to some of the stuff you're worrying about. So I would love to hear kind of like or summarize at least some of your
Yeah.
skepticism about that.
So I think the first thing from our discipline as psychiatrists is that burnout is, like you said, is an occupational phenomenon developed by a psychologist, a couple of psychologists who came up with this construct. And then when it comes to adopting this in terms of this context of is burnout a mental illness, it's not according to the DSM. And there was an article that came out, I think, 2 years ago in, I think, like JAMA Psychiatry that basically just said, you basically miss out, or because there's so much overlap with this emotional exhaustion component with work. Because if you think about it, somebody who has an underlying mood disorder like depression is probably going to be emotionally exhausted at work. Now, being able to sort of screen that out in terms of saying whether or not somebody who is emotionally exhausted at work is only emotionally exhausted at work versus not at work, that's something that I think some psychiatrists have been perhaps a little bit unwilling to consider this diagnosis as something that's treatable. I think for me, obviously, I have a burnout podcast, so I'm not in that realm, and I don't really necessarily agree with them. But that's something that they've certainly put out there. The other thing that I think is actually pretty valid when you think about it is how burnout is studied. You mentioned that in your pilot study you had 12 people that you followed, and you're basically using the MBI as an instrument. And I think there was a study, I think it was also in JAMA as well, that basically said if you take a meta-analysis of all of the burnout literature, people are like that big article that said 50% of all doctors have burnout. They basically use a modified MBI where they had like two questions. They asked two questions, and then they sort of said, well, it kind of correlates with the entire like item survey. So we're just going to do it because I think from a pragmatic standpoint, it's really hard to do a 16-item survey for like every, like I don't know how often you were actually following them, but to have a sample population and actually do 16-item surveys every day or every week, it gets cumbersome and people are going to get tired of it. So I think that's also something that's pretty valid, in my opinion, in terms of why stick to the 16-item thing about this burnout construct. Why do we have to be so nitty-gritty about this? We need to come up with something that's broader and that's more socially accepted. So those are pretty much the 2 points that I think are worth kind of bringing for the discussion today.
Yeah, no, I think I completely share your concerns about that too. I think maybe just speaking first about the assessment. I think first from the assessment of burnout, it's really a challenge because I actually was really curious even about the history of like the Maslow and looking at like Dr. Maslach, her initial work, kind of looking at this and where it was like the psychometric properties about this and where it was validated. And it's been used in the healthcare settings multiple times now. So it's been, quote, validated. However, if you actually look at the questions, you actually run through the questions, they're not as very like what I call like externally valid. It's kind of not as practical as some clinicians, a lot of clinicians sometimes would ask me like, why the heck are you asking me? This question doesn't seem that relevant to, say, a trauma surgeon or to, addiction psychiatrist. And it's true because I think that it was kind of like created in this idealized vacuum of like trying to operationalize depersonalization, emotional exhaustion, et cetera. But it didn't, I think there's kind of time is ready for what I consider a more clinician focused kind of assessment of psychological stress. And whether that construct is burnout the way that it was initially envisioned or something actually different, I mean, that the data will remain to see. There's been a group at Stanford that has kind of like tried to pilot this. I mean, I know that Dr. Shanafelt has been kind of this like leading the way with a lot of clinician wellness and clinician psychological stress, and his group at Mayo and now at Stanford, because he's at Stanford, has really led the way for that. Their survey is a little bit more tailored, I think, to kind of the clinician setting, but I think it's still kind of behooves the question of the timing of it. Like I talk about burnout occurring or psychological stress occurring in different phases in a shift. Like I could start a shift just like you can remember, you can start like, a day in clinic or on the wards feeling great. And then you have a really kind of intense situation. You feel very stressed. and then 2 hours later you're feeling great again. And like there's these, it's a very like dynamic situation.
Yep.
And how do you capture that individual cadence, the dynamic stress? I would argue that you really can't capture that as much right now with something like the Maslow, which is I think a little bit more of like, kind of as an analogy, it's like kind of like your A1C for your sugar levels, whereas we need something much more dynamic with like your serum glucose. So I think there's a tremendous opportunity, and this is for all the listeners, for from a research standpoint, to kind of create a survey that's really more dynamic. We're trying to. So with the research that we're doing, it's a funded study from NHLBI, from the NIH, the National Heart, Lung, Blood Institute. So thank you, Uncle Sam. It's going to be looking at a longitudinal study following nurses and physicians and PAs and NPs and looking at their psychological and cardiovascular health. And initially, we were like going to try to bootstrap kind of our own burnout inventory for this. But when we got it, it's one of those challenges of which comes first, the chicken or the egg, right? So the reviewers, that really great reviews, very insightful, they were like, well, this survey that you want, is it validated? How do you know it's really going to really assess burnout? Why aren't you using one of the more standardized instruments? And at the end of the day, I said, you know what? Fine, let's just use the Maslow. And I think there's a part of me that, I mean, we're going to use the Maslow, but we're also going to try to include some more what I call dynamic or time-sensitive questions to see how that matches up. And I think if any of the listeners have any other ideas for how to assess, near real-time psychological stress, please reach out to me. I'd love to collaborate with you, because I think we need to like kind of re-envision this, how it's done.
That's really, really interesting that you bring up the idea of more so dynamic changes. And I think one way that has been done, perhaps in monitoring patient symptoms, for example, is the use of technology. So using apps to get how people are feeling in real time, and to also be able to have a comparison. So having someone be able to track their actual emotions, feelings every day of the week. So you're just working with more data, essentially. And I think that's potentially one way that we can perhaps make this more like clinician focused, as you said, or more dynamic. But I think that's hard, because in a clinical environment, you don't want to obviously be on your phone all day either. And
yeah, it's a great point, Varsha. And I think it's something that in trying to create this study, we encountered some of the pilot work. So initially, from the cardiovascular outcomes, we actually are collecting a lot of passive data. So we have like people wear a Fitbit that kind of collects their accelerometer data, and we have some information from like a Bluetooth blood pressure cuff that it kind of helps with their cardiovascular issues. But we initially were going to try to do something like what you're saying, like pushing like notifications for you to fill out like this quick one item stress survey. And we got a lot of pushback from the nurses and doctors, because they're saying, we're in the middle of this busy shift, and now you're like doing Bluetooth, you're pushing to our phone, and et cetera. And I don't know what the best solution is. That is some passive data collection that we kind of infer from like we collect data on like, say, patient acuity levels, and we later infer like your heart rate, things like that? Or do we actually explicitly ask them? I don't know the answer to that. I think it would be a great study to find more of the dynamic changes of stress that I think with all these new devices and the new technologies, I think it's a real great opportunity to start kind of like crunching that. And I think I'm not like a data scientist. I'm not a computational scientist by training, but a number of my co-investigators are. And one of the questions that we're trying to think about is just like, computational methods have really kind of revolutionized ways of like reading EKGs or understanding like ejection fractions from echoes. Can this big data, quote unquote, really be useful for helping us as mental health experts in terms of understanding near-term stress, or some near-term adverse event? I don't know. I mean, hopefully it will, but I think the jury's still out.
Yeah. I did want to go back on something that you were also mentioning with your previous research with patients, and the fact that some of these patients who had an ACS, a lot of them ended up developing PTSD symptoms. But I do think that, in terms of what you're describing in terms of a busy shift, or, what happens in the emergency room, that it can be traumatic for a lot of these clinicians. And what we're seeing, there's this huge overlap with PTSD and burnout.
Yeah, no, I agree completely. And I think that whether they're, just thinking about it from a construct map, whether one is like potentially mediating the other or precipitating the other, or is it simply associated, or are they really just kind of the same construct, that we're just calling it something else. I don't know. At least from our past work on patients, is that the PTSD that is exhibited in the 1 in 6 survivors of ACS events actually has some significant consequences, not just psychologically, but also cardiovascularly. And I think that's what's really concerning for me, for our clinicians. The data that we have from our group, we found that individuals who have an ACS event, who go on to have PTSD, they have actually a 1-year all-cause mortality of almost over double compared to individuals without PTSD. And so I think there's a couple hypotheses about this. Could it be due to with the inflammatory processes or the increased cardiovascular risk? We don't know yet. I mean, we just have that as an association. But what I worry about is for clinicians, this could be something that actually could be really impacting our physical well-being too. And that's why for our study, we're really looking also at cardiovascular health among providers too, because I agree, no matter what you call it, burnout, PTSD, anxiety, moral injury, there is something that's actually really significantly impacting a lot of our colleagues, and how that impacts our long-term well-being is something that we really need to pay attention to, both for our friends and our colleagues, but also for the profession of medicine, because I think it's that I always say that happy doctor, happy physician, happy patient. And I think there's been past work that's found that physicians who endorse high rates of burnout also have poor patient care. And so I think this is actually an issue that shouldn't just concern us as clinicians, but it should also actually be something that worrisome, very, very worrisome for the healthcare industry as a whole.
We had a guest a couple of episodes who was an emergency medicine resident, and she actually mentioned a lot of really interesting things that I think are similar to what you brought up in terms of the work that emergency medicine doctors experience and how it kind of leads to people having burnout or kind of having impacts on their physical health. One of the things that she mentioned was that I think her first year they were doing 12-hour shifts, and the residency pushed for it, or there was some sort of data that came out that said that if you did more frequent 8-hour shifts, even though the total amount of work was higher during the week, that a lot of the residents actually found that the more consistent schedule was better for their own personal well-being. So that's something that she anecdotally basically said it led to an improvement in terms of her well-being. The second thing that I think is really interesting to note is also, emergency medicine, I think from a overall perspective, as doctors, we usually think that they tend to have higher levels of burnout. And for her, what she observed is that a lot of her attendings, I don't think she had any attendings that were over the age of 60, for example. So all of the attendings were on the younger side. Mm-hmm. And the other thing that a lot of her attendings basically said was just that you should really figure out something to do other than working in the emergency room, because it's going to wear you out. You should do research or something.
Like figure out a niche that would be helpful, essentially. So it offshoots or offloads some of that burden or distress that you have from working long hours and long shifts. So it was so interesting because I know Andy and I at that time, we were like, isn't this crazy that you're very enthusiastic and excited about a field, and then you're being told essentially you should also find something else to do on the side because you can't do this forever. And that's a problem. That's a really big problem.
Yeah. I guess, Bernard, my question for you is, do you actually offer that to residents that you supervise? Or, what's your take on this whole, people in emergency medicine need to reduce their work in emergency medicine to continue on?
Yeah, no, I think it's a really, really insightful question and a comment actually from the previous guest, because it is an interesting observation too. When I was a resident too, I noticed that a lot of my mentors and a lot of my attendings were either on the middle-aged, youngerish side. Rare to see someone whereas I would see one of my neurologist attendings was in his mid 80s, kind of attending on the floor. And it was incredible just, seeing someone who's kind of been in the field for, decades. And you don't see that as much in emergency medicine. Partially, I think it's because of, some of the way that the occupational stresses of it are designed right now, that I think you have that shift work, that sleep dysregulation, you have that acuity behind that. I would say though that, and I think that there are definitely pathways. I think you'll see a lot of individuals, especially within academic medicine, kind of fall along different pathways where they either become like an administrator, education, and research, and their number of full-time clinical shifts, dramatically reduces. But there is a counterpoint to that. If you look at the community, like for example, my wife. She's now back at Columbia, but she was previously at a community hospital, and she had a number of colleagues who were like much older who've been working for decades there. And I think it kind of boils down, I think, to kind of your occupational work environment, because I think that if you come up with a system where the clinician feels protected, is allowed to have kind of like aspects to enjoy their own personal well-being, then I think that for those folks who really enjoy the content of the work, it's a sustainable profession. But I think the challenge right now is that, particularly for residents, because the house staff are just exposed to extraordinary amounts of psychological stress, both from learning, hours, in addition to all sorts of other different stressors, that it's a very, very kind of vulnerable time. And especially earlier attendings too, because you're kind of scrambling, trying to find your niche. But I think the onus really is also on our specialty too, to think about how do we re-envision a healthy work environment to kind of make it sustainable. I think it's out there. I mean, seeing some of the community docs who've been practicing for decades. But I think that it's still like uneven. And I think it's something that we really have to kind of struggle and kind of work with kind of going forward.
Okay. Yeah. I do have some questions. You mentioned this whole sense that, if you work in the community, you may see a lot of people or doctors who are able to work for very long periods of time. But, the stereotype, at least for me, for when I hear about doctors that tend to stay in academic centers or are involved in academic medicine, those levels of stress are a lot higher, or perceived to be. And, I guess, you're an academic physician, and in terms of, seeing it anecdotally, is there anything that can be done about this particular academic setting as academic physicians?
Yeah, so it's a very interesting challenge I think academic physicians encounter. I think on one level we've been talking about over the last few minutes, kind of talking about the occupational stresses as a clinician. But I think in parallel to that, as an academic, you also have a unique set of stressors as well. I think both as a researcher, there's a unique set of challenges and frustrations and hurdles from that standpoint. But then there's also, no matter what role you do as an administrator, as an educator, operations, I mean, there's always going to be these other type of responsibilities and stressors that quite frankly don't get talked about as much. And I've had this conversation with a number of researchers, and we've talked about this idea of like researcher burnout or admin burnout. And it's this kind of dissonance that you have, because on one level, speaking as a researcher, I love research. I love asking scientific questions. And then you find yourself extraordinarily stressed sitting at some random hour on a weekend doing research and saying, what the hell am I doing? What this is like crazy. And it's this dissonance of like, kind of, you wanted this so bad and now you have it. You're still extraordinarily stressed. And I think I can't help but wonder if that, exacerbates some of the stress that some of these folks feel. I think also too, it's a little bit of a challenge from the standpoint of a support network too for a lot of academics, because I think there really is this unspoken kind of cultures, for lack of a better word, that you have to do certain things to kind of advance through academia. And I think when you feel like you're getting a self-perception that you're falling behind or you're not kind of like meeting up those standards, that also kind of exacerbates the stress that you might be experiencing too. And I think it goes again to this idea that we're beginning to recognize among clinicians that having peer support is really, really vital. Particularly, over the last few months during COVID, we've had a number of like peer support groups among like the emergency physicians after seeing all the stuff that we've been doing here in New York. But we don't have that for a lot of research, a lot of young investigators or a lot of even established investigators. I think that's something that I think would be really, really helpful, really important, because they face a unique set of stresses. Both of you are in kind of like the Harvard universe. I trained there too. I know kind of that bubble is extraordinarily, on one level, you're surrounded by extraordinarily talented and really, really creative folks. And it's a really, really fertile environment for just anything. But on the flip side, there's this also intangible stress or anxiety, at least I felt myself at times, of trying to kind of like meet up to standards or trying to meet like kind of your mentors or your programs like unspoken expectations. And I think that it may not be the fault of the program itself, but it's kind of this almost implicit acceptance of you are here to be excellent. And I know we need to challenge that presumption, I think.
Absolutely. I think that reminds me a lot of the conversation that we were having with a couple of medical students who had come on a few weeks ago as well. And it's the idea that this mindset of needing to strive and achieve greatness, this perfectionistic kind of behavior, it becomes a habit that starts pretty early on, I would say. So I think when you start off, for example, high school, undergrad, it starts as early as then thinking, okay, I need to do the best that I can. I need to do more than I've done before. You just continue to keep that mindset until, residency comes around and now you're about to be an attending and you still think, hey, it can't just be all work. I have to do other things in addition to that. I have to involve myself in academia. So I think that pressure is always there, but I think it's out of habit as well.
Yeah, no, I kind of half joke sometimes that it's both like the biggest blessing, but also kind of a strange curse to be allowed the opportunity to be like a physician. Because on one level, it's a blessing, like it's a phenomenal opportunity to like work with patients and see like really crazy intelligent colleagues and work with staff across the hospital. And your opportunities are like endless in a way. But in a strange way, because the opportunities are endless, it gives you this undue pressure now that you have to kind of meet those opportunities. And I think to your point, Varsha, it's like when you're a med student, it's like, I want to get this, if I can just get it, no, when you're a college student, if I can just get into med school, and then you get into like your dream med school, and it's like, if I can just get into this dream residency. And, I thought that it would end as a faculty member, but it's, I kind of caught myself in the same kind of rat race. It's like, oh, if I just get promoted, oh, I got promoted. If I just become like, like a vice chair, well, and then you see now you keep looking and looking, and you kind of have to catch yourself and recognize that celebrate kind of what you've done, and B, also recognize that your external motivations like that aren't really kind of what make you, at least personally speaking, what make you happy. And I think it's why it's all the more reason for maintaining your social context, your personal friends, your family, finding passions that, beyond medicine too, that kind of gets you jazzed. And I think it sounds very cliched, but it really is vital in terms of helping your kind of ego and your sense of self in terms of understanding that. Because when you fail, and we all fail, and that's inevitable, everyone fails. When we do fail, that we can accept that it's okay. It's okay to stumble. It's okay to trip. Because I think what I worry about the most sometimes with among our colleagues is that we have these really superstars, and I think that, this top of the class in high school, college, med school, residency, faculty, and then they have their first stumble when they're like pretty far along their career and they're extraordinarily devastated. And I think it's one of those reasons why I always kind of joke with a lot of my friends is that you want to like fall flat in your face early and often, because it's like getting your heart broken. It's really, really terrible, but you kind of ultimately recover, and you begin to realize that as painful as it might be again in the future, you'll recover. And I think that idea of getting that lived in experience is important, but we need to also create that environment that folks feel that they can do that. Because I think right now, it's this perfectionist attitude that's really challenging, I think, for a lot of folks in our field.
Well, I think it's all about the environment that you're in, right? The culture of the place, that the institution that you decide to work in, or I
Yeah.
mean, the one thing that really drew me to BI, for example, is just that I felt like from our interview day, I remember pretty distinctly that the chair of the department said, I don't care if you become a chair of another department one day. I don't care if like one day, I don't care if you decide to do like private practice, or if you decide to open a clinic, or if you don't decide to do academic medicine at all. I'm just like, and I think I like that message. It's the idea that you don't have to constantly strive for some, unattainable greatness. It's okay to also be a doctor. Like, I mean,
Yeah.
and I think sometimes we lose sight of that and think, oh, we got to do more and more and more. But since when did it become that, being a doctor is not a good enough achievement, which is crazy.
Yeah, no, I agree 100%. It's funny, like sometimes our chair, she'll have me like, I'm like kind of the poster boy for the research stuff, but like oftentimes like after they talk with me, she's like, what the hell did you talk to them about? They don't want to do research anymore. And I'm like, it's it's like I'm half like subversive because I always say that, I think for me, I enjoyed it, it worked out, but that's definitely one individual, and you can't make these like broad assumptions or broad observations. And I think it's going to be cultural. I think it's really nice though that the fact that this generation of physicians, like our generation, is actually a kind of awoken to this, and b kind of understanding or the flexibility of like the importance of like the educational lines, the clinician lines, and all those other kind of the contributors of medicine. And at the end of the day, too, I think Varsha brings up the best point is that it's very abstract. Like for all the grants or all the stuff I do, when I talk to my mom, she's always asking me as like a doctor question. She's asking me about like I have a sore throat or what. She has no idea
Yeah.
what R1 is. And
Exactly.
it's very, very heartening actually, because at the end of the day, like as much as I'm like all focused on like my NIH progress report or grant, whatever, at the end of the day, like when you hang out with your friends or you're actually talking to like people that you really care about, it's like your role as a provider and your role as a clinician that really counts. And I think we can't lose sight of that. You always have to remind yourselves too. Like I try to tell like our medical students and our residents about that when they're stressed about those things, that you've done so much already. You're like the 0.0001, but you're like phenomenal. And so please don't think you're like any less because you're not doing research or you didn't get that grant or whatever. And I think you need to have that modeling, and it starts from the top up. And I think slowly, I think as this generation of younger providers, as we kind of move up the food chain, we stay in medicine with a lot of people. That's a separate conversation with people leaving medicine. It's going to be important for us to kind of like model that behavior, I think, for the students and like the ones that come after us.
So I wanted to change gears a little bit. What has your experience been like thus far, being in essentially the center or hub hotspot for the pandemic in New York?
So it's really been, a pretty extraordinary experience, I would say. Um, I've done some work outside of the US in kind of like more healthcare challenge situations. And I just never would have thought in my dreams that one day I would be kind of in a similar situation, but, in my hometown. I'm from New York City, like my hometown. And it really was kind of I think for three broad reasons, it really just extraordinary like moment, I think, for a lot of clinicians. I think the first is that, from an acuity standpoint in the ED, in the heat of it, probably I would say like mid-April probably was probably the worst of it in New York City. Just the pure volume, the acuity, and the type of resource allocation that you just never would have thought would have ever run into, like running out of oxygen or ventilator machines or PPE, things that, buzzwords that I just took for granted that a mask was a mask. And now I was thinking about rationing the masks for myself. I think the other thing was that I've always viewed the ED, the hospital in general, as like a safe place. Like I know that there's some like challenges sometimes with certain patients or certain situations, but I never feared for my own well-being going into work. And that really changed, I think, during the peak of COVID. I think there's a lot of unknown variables about how the disease was transmitted, as well as you impacting yourself as well as like your family. And I think that was really, really stressful for me. And then I think lastly, just from the overall societal like restrictions that were imparted by the government. And I think it was like, I personally think was like probably the right thing to do, but still nevertheless, like, you're extremely socially isolated. You couldn't go out. You couldn't do pretty much anything. And I think that combination really created a significant amount of stress for myself personally, and I think for a lot of our colleagues. I think we just published an article in General Hospital Psychiatry that looked about 600 Columbia healthcare providers, and we found that basically almost 60% of providers, particularly nurses, had like acute stress symptoms, and they had insomnia, very like significant anxiety and depressive symptoms. And I don't know how durable. Hopefully, they won't be durable. How long those symptoms will be, but at least from like the snapshot that we had during like the peak of the pandemic, we had a significant amount of psychological distress like among us. So I'm hopeful, now seeing this being played out across the country and other hotspots now, I'm hopeful that our colleagues out there, in other states are being supported and, being protected, because I think it really was a pretty traumatic time for us, like in New York a few months ago.
Absolutely. I think, if there's anything to take away from all this, I know that the aftermath of of this pandemic is certainly going to be far-reaching in its consequences. And I think I definitely think what worries me a lot is that, especially when you think about trauma in the short-term and long-term effects, it's like not necessarily time limited for everyone. Everyone reacts a little bit differently. But what I am afraid of is will there be enough providers, for example, or mental health clinicians to even handle the number of patients we're likely going to see?
I think that the good news is, at least I was talking to one of my colleagues here at Columbia at Teachers College. He's a psychologist, George Bonanno. He looks at PTSD following like disaster situations. He's done some work previously in Nepal as well as Haiti and with the Ebola pandemic a few years ago. And I think the good news on one level is that I think most of us will be okay. That's the good news, right? So the good news is that it seems that most of us will kind of recover and most of us will be okay as healthcare workers. But the bad news is there will be a significant minority of us who will have some durable psychological kind of consequences from this. And whether that is ultimately diagnosed PTSD or some generalized anxiety disorder or some type of DSM category, I don't know. But I think nevertheless, of whatever you call it, there's going to be some type of mental health impact on us. I think that it kind of now turns into like, what do we do about it? The first is, I think, how do we screen or identify these individuals? How do we create the proper resources and structure to support them? And then lastly, how do we kind of like help make sure that they are adequately supported and treated in the long run? I don't know the answers to all of that, but at least speaking here at Columbia, what we've tried to do is we've tried a new model where we do an opt-out program for our faculty. So rather than we all have talked with a mental health specialist, all of us, and if you don't want to, you can always opt out, but otherwise you're just kind of automatically assumed to like just chat with somebody. And that's been like tremendously useful, I think, for a lot of our faculty in terms of at least getting a first point of contact with a behavioral health specialist. I think that also recognizes with peer support groups, both formal and informal groups, kind of on WhatsApp or like Facebook, et cetera. I think that's also been very useful for people just to kind of have peer-to-peer support. But I do agree with you, Varsha, that there is this looming kind of like event that's going to be affecting us as a profession that we're going to need to get ready for, and we're going to need probably a lot of help from you both, the psychiatrists and the psychologists and the behavioral health specialists out there to kind of help us get through this.
We got a good discussion today. Do you have any last words for the listeners?
Yeah, thanks again, for listening. I think it's really important to seek out podcasts like this or kind of like groups, communities like this who recognize the importance of psychological well-being among us in this profession. I also would like to just say that you are not alone. I know that at times that you might feel like an isolated silo, but there are colleagues and friends across all the specialties. We're one large community, and we all are kind of invested in like the mental health and the psychological well-being of our colleagues. So I say to everybody, listening, hang in there. We're rooting for you, and please, if you ever have any questions or any I'm always very curious to like talk to other people who are interested in this field too. Just reach out to me, and look forward to like chatting offline.
Shrinking Burnout is a podcast about furthering the discussion of clinician burnout and recognizing the resilience and hard work that clinicians regularly demonstrate. Nothing on this show should be taken as medical or psychiatric advice. All of the opinions expressed on this podcast are solely our own and do not reflect those of our employer.